Hello, everyone. Welcome to the Empowerment Series. My name is Kevin Ballister. I'm a neurotrauma medical advocate, author, speaker, host podcasts, and I am here with someone I have so much respect for. This is Dr. Peggy Mason, a neurobiology professor at the University of Chicago, who I learned from through massive open online classrooms back in
2014, I think.
2014. Yeah, I took her neurobiology course, and I've just been following Peggy and so appreciative of her work. And actually, the last time I was in Chicago, we got together, which is amazing.
We did.
Yeah.
We cooked and we drank.
Yes, we did. Yeah, I even got some like mixology skills on
Yeah.
it.
Well, the only bad thing was we didn't have brains.
Yes, I know. We've been talking
future.
about eating brains together for a while.
Yeah.
Yeah. Peggy goes to France every year, and you invited me the first year, and I didn't make it. Should have made it. Made that happen. But yeah, you go and you get brains.
Yeah.
And
Yeah.
I love it. And I know people get screamed out about it, but hey, they got nutrients for your brain.
Yeah, it's tasty fat.
Nice, tasty stuff. Yeah. Well, we're here to talk about the neurobiology of in the age of COVID.
That's it. That's exactly right.
That's where we are. And
yeah, that's where we are.
let's like with COVID, you're a fantastic person to speak of about neurological complications with this this virus, what we know, what we don't know.
So what we know right now, what we're seeing a ton of, or not me. Oops. Sorry about that, folks. Okay, here we go.
Dropping our audio.
So what the neurologists are seeing are these stroke wards that are full with people that are 30 to 40 years younger than the normal, than what they're used to. So usually a stroke ward is filled with people 70, 80, 90s, a smattering of people in their 60s. Now it's filled with people in their 40s and 50s, with a lot of people in their 30s and even some people in their 20s. And that appears to be a result of this coagulation issue that COVID appears to be one of the direct effects of the virus. So, you have direct effects and indirect effects. And it looks as though one of the direct effects, besides doing all the stuff that it does to the lungs and now all this stuff that it's doing to heart tissue, to cardiac muscle directly, it's also affecting blood vessels. And it's affecting blood vessels, and it's affecting blood. So the blood is coagulating.
Mm-hmm.
And this is producing blood clots. There's the, I guess his name is Nick Cordera, who's a Broadway star, who unfortunately got a blood clot in his leg, and the leg was amputated. The blood clots are the basis for some. I don't think anyone thinks it's all, but some of the COVID toe is due to a blood clot that's just blocking blood flow to a part of the foot, typically.
Tell me about COVID.
Causing necrosis there at the foot.
So tell me about COVID toe.
So COVID toe is people. It's like what people have called chilblains. It's essentially a red, inflamed, blistering sore that can open up, typically on the feet, on the toes, but it can also be in the upper extremities. And these come, they pass. For the most part, they pass. Some of them are quite severe and may require even amputation of toes. So that's another complication. But as far as neurological, I think that it's easy to say that the biggest complication or the biggest reason why neurologists are seeing COVID patients is because of stroke, because of this coagulation issue. Another thing to remember is that a friend of mine, I have quite a number of friends that are MDs, so they tell me things. So I don't have direct experience, but indirectly they tell me that, for example, I had a friend who was working in the ER, and she's still a physician in training, and so at that hospital they weren't allowing the interns to see COVID patients. They had the COVID ward was for attendings and residents and people with more experience. So while she's working with these people that are coming in because they've had a car crash or because of some other reason, they're testing them all. And an enormous proportion of these people that are not coming in for a COVID reason, they're coming in because of trauma or an accident of some type, and they're testing positive. So you have to wonder what COVID is doing to brain function, essentially to judgment and to focus and attention, perception, motor reflexes. We don't know. That's the real answer. We have no idea. Because one of the big problems is we have no idea who's positive, who has been exposed or is currently has virus in their body. We don't know.
And from us not knowing, like you're saying, what we were talking about earlier is testing being, sometimes we have false negatives with testing. And what I always wonder about is if it's faulty testing, if there's also false positives. What are your thoughts about that?
The evidence suggests that there are very few, if any, false positives. Right. So we can take the positives to the bank. They're positive. Mm-hmm. The problem is that we have, the current estimate that I've read is 30% false negatives, which is ridiculous.
Right.
And so as we were speaking before we got on here, a typical situation is that somebody gets a cough and a fever and is really worried and goes into some testing site and gets back a test that says that they're negative and breathes a sigh of relief, which is just completely unwarranted. So in Wuhan, when this first came out, they were very well aware of this high proportion of false negatives, and they made the judgment on a clinical basis. So if a person they would take an X-ray, and if the person had the pneumonia that is very indicative, that is a sign of COVID, that person had COVID, regardless whether they tested positive or negative. Right. I remember the New York Times had this article of these two healthcare workers, both of whom got COVID, one of whom died, one of whom lived. And the one who died, I don't know how many times she tested negative, and she died. I mean, she had COVID, she died of COVID. So a negative test is not meaningful. It's not. It doesn't mean you don't have it at all, particularly if you have the symptoms. So why do we have such a high number of negatives? Part of it might be technical. It's you kind of got to spelunk up into the nasal cavity, and I think it's not a trivial talent to be able to get up there and to have the person tolerate that.
Yeah.
So I think that some of it is that people aren't getting in there quite enough. Some of it might be the actual laboratory test. And then I think, but I would imagine, and this is just a guess, I obviously could be wrong, but that some of it is just because there's not a ton of virus in the nasal passages in that particular patient.
Mm-hmm.
That particular person has it else, has their viral load concentrated in other tissues, and they're not accessing those.
Interesting. Yeah, we talked to Laura Bedell. She said it's nasopharyngeal swab, which means they stick a really long Q-tip all the way to the back of your throat through your nose. And
Right,
that's not comfortable. And also what you're saying is there might not be virus
right.
in that particular area. And it might
In
be
that particular person.
right in that
Right,
particular person. Right.
right.
So
And I think that, the thing to remember is that we all share this discomfort. It's not just the person getting, receiving the swab that is uncomfortable. The person doing it is not having a good time either.
yeah. Yep. I hope they're not having a good
No,
time.
they're not having a good time. And, people want, to, they don't want to, I remember I was, in my other life, I think that I study helping in rats. And so I give talks to all sorts of people.
Right,
I
right.
gave, and a
Empathy
friend of
in
mine,
rats.
what's that?
Empathy in rats.
Empathy and helping in rats. Yeah.
Yes.
So I give a lot of talks, and a friend of mine asked me to talk to the Department of Surgery. So I did. And it was funny because he said to me later, he said, helping is not always comfortable. I slit people's throats for a living because he does thyroid, surgeries. So he's helping, but he's hurting. You have to hurt to help. And these swabs are essentially a hurt to help situation.
Right. Yeah, it's I had a throat surgery by Dr. Brett Miles, and I wrote a post about it called "Slitting My Throat to Save My Life."
Exactly.
Yeah,
Exactly.
yeah,
So, you would think that slitting your throat is an antisocial uh, action, but in fact, in many situations, at least at the hands of a surgeon, it is not at all an antisocial. It's actually a very giving and pro-social action.
it's like tough love times a billion.
Exactly.
Yeah, yeah.
Exactly.
Absolutely.
Yeah.
So, I wanted to talk about some neuro complications again. We were talking about clotting, and we talked to Laura Bedell, a registered nurse at the second hardest hit COVID hospital in America. And she talked about clotting happening, strokes, all of that. And before we got on, you were telling me about Guillain-Barré increasing in Italy.
So what the clotting produces strokes, and so the stroke, which is the neurological problem, is a secondary event to the clotting problem.
Right, right.
But it's very possible and probable if we look at past pandemics. So most notably, we've looked at the 1918 flu, but also people have looked after SARS and MERS, and these epidemics, whether they're flu or coronavirus epidemics, the virus itself either attacks directly or elicits an antibody reaction that then causes an autoimmune just problem. And it can attack all sorts of targets that are in the body. And one of the things that it appears to attack is the myelin in the peripheral nerve.
Mm-hmm.
And that causes a Guillain-Barré-like syndrome. So Guillain-Barré, I think everyone's heard of multiple sclerosis. That's the most common central demyelinating disease. The most common peripheral demyelinating disease is Guillain-Barré.
Right.
If anyone's a Tales of the City fan, John in Tales of the City had Guillain-Barré. So it is typically transient, and people typically make a pretty decent recovery. They get back to, say, 90% or more. But a Twitter follower sent me an article from Italy showing, I don't know, I thought it was something like 15, 16 cases of Guillain-Barré, all of whom had were in COVID patients. And, Guillain-Barré is just not that common. So that has the ring of truth to me that the virus is causing Guillain-Barré, either because the virus is attacking the myelin or because the virus is eliciting an antibody that then attacks the myelin. Which of those I don't know.
Right. For our audience, quick neuro lesson. So your central nervous system is your brain and your spine. Your peripheral nervous system is basically everything else that your nerves are a part of, which is just about everything else. And the myelin is what wraps around the axon, and that enhances the speed of the signal. And so when the myelin is taken away, and these are both autoimmune conditions, which means the body's immune system or the brain's immune system is attacking the myelin sheath, or it's damaging the myelin's sheath, which is what increases the speed of our neuronal signals. So this really slows down the communication of our nervous system. And you said Guillain-Barré. There's
So it's beyond even slowing it. It also disorders it.
right.
So if I send the telegraph code 1001001111 to move this muscle, and that gets screwed up by one or two zeros or ones being mixed up, then then my muscle doesn't know what to do correctly. It's poorly timed, it's weaker, and so on. So disrupting the myelin sheath, even if there's not a frank block of transmission, it slows and the message is garbled. You wouldn't be able to get it. The telegraph operator is not going to be able to interpret the zeros and ones.
Gotcha. Right. So it actually distorts the message.
It distorts the message. That's exactly right. Yeah.
All right. And so the recovery rate of Guillain-Barré, you said it's pretty good.
It's very high. It's very high. And now I don't know whether that, is this syndrome that's being seen in COVID patients, is it the same as typical Guillain-Barré, which is episodic, but is it the same? I don't know. And I don't know if these people have recovered, and I don't know if they died of COVID anyway. So it's unclear.
Yeah, and there's a lot that's unclear right now because we have a novel virus. I mean, we haven't seen this before, and the long-term studies don't exist because it's not long-term.
That's right. I mean, most of this is a we don't know, and
right.
I think that there should be a very healthy use of the we don't know answer to this. So, for example, people who have COVID, many of them are confused, or they're somnolent, or they're comatose. Is that actually a specific effect? Is that going to become a syndrome? Is there going to be a COVID fog?
Right.
We don't know that.
Mm-hmm.
Possibly it's just because they're sick in so many other ways. Their blood oxygenation is so low that they are confused. We don't know. So those are issues that we're probably too close to the ground to get to right now. We're going to need to be high in the sky a few years from now to figure out which of those things were direct neurological hits that we took.
Yeah.
So related to that is one of the things that has come about from 1918 flu. Well, first of all, there was a very specific neurological condition called it's the subject of what Oliver Sacks talked about in Awakenings. So it's encephalitis lethargica, I think. And it's a very specific post-1918 flu encephalitis that produces a Parkinsonian-like condition. And it developed in, say, between a couple years and, say, 10 years after the 1918 flu. And we've never had, and it was a direct consequence. No one disagrees with this. It was a direct consequence of that, and it has now disappeared. The last of these patients, I think, I don't think there are any patients remaining from that. But in addition, and so that's a small number of patients, and it was a real problem, and it was very interesting because it was a young physician, a 25-year-old physician named von Economo, who recognized that this was an entity, that this was a problem, and he named it. But now we have, but after that, in the 10, 20, 30, 40 years after 1918, there appeared to be an uptick in people who had the 1918 flu, recovered, and then developed Parkinson's. And so one idea was that 1918 flu made people susceptible to developing Parkinson's with more increasing, as they aged. Now, my grandfather had the 1918 flu and he got Parkinson's, and it was always, it was lore in our family that was at least one of the hits that he took that contributed to him getting Parkinson's. Possibly a hit, possibly the only hit. It's really, really, really hard to know. Mm-hmm. But I would not be surprised if in the decades that follow today, we start to see suggestions of an association between COVID and all manner of sequelae, whether they're neurological or not. So, we might have an uptick in some lung disease or in some cardiac disease. We're not going to really know whether that association is real for a while. Mm-hmm. You just don't, my grandfather had many reasons why he could have developed Parkinson's. Bad luck. He was a forester and he was exposed to pesticides. And he had the 1918 flu. Which of those, which one or which grouping of those was important, it's impossible to say. So this is a job for epidemiologists who get very clever with statistics and numbers and comparisons. And it's typically an answer that holds for a population, but not for an individual. You can't point to an individual and say that person got sick because they had COVID. Right. And that person didn't get, that person got sick, had COVID, but got sick for a different reason. That's typically not the kind of answer that we'll ever be able to get to.
Yeah, none of us are like living in isolation. There's no isolated variables happening that can say it's definitely this.
Yeah, and stuff happens. In 20 years, some proportion of us are going to get Parkinson's anyway.
Right.
So what's to blame? That's a crapshoot.
Yeah. I was curious, and actually I'm not sure if you know that much about it, but knowing you're pretty up on medical history. So I was curious about the history of novel viruses coming into our hitting the globe. What the last one might have been.
Well, the last one was SARS. I mean, but it didn't quite hit the globe. But SARS and MERS, they were very different because they flame out because they're much more lethal, and also because they were only contagious. A person had to be symptomatic to be contagious. The real killer with with COVID is that you can spread it without knowing it. That's just a big problem. So yeah, I mean, the history of pandemics and sort of kill-offs that are due to microbes is a long history. I mean, so for example, the Native Americans were killed by not as much by war, but by microbes.
Mm-hmm.
All sorts of bugs that the Europeans brought over to the so-called New World killed the Native Americans. I mean, they might have killed them anyway. I'm not saying that the Europeans were all kumbaya and they wouldn't have killed them anyway, but they killed them unintentionally. Most of the deaths were unintentional because they communicated these microbes.
Right. Have you read Guns, Germs, and Steel?
Yeah, absolutely.
Highly recommend that book to anybody out there for history of how this country and many other countries have been taken over with those three things. So I've been spending a lot of time on my computer, which actually isn't that different today, but it's like definitely on Zoom more often.
Okay, so here's the thing, Kevin. Are there aspects of Zoom that you like? What aspects of Zoom do you like? What aspects of Zoom do you dislike?
Oh, you're asking me. What aspects do I like? I like that I'm able to speak to people all over the world in real time, and to see them. And while we can't really make eye contact, it's closer than than over the phone. And Kitty says hi, by the way. The other one too. So
okay, I think I just have to tell your listeners that one of the most awesome things about Kevin is that he has 4 black cats. Okay, 4 black cats. Now that's something to admire.
is I inherited it. Just to be clear, I inherited these 4 black cats from Oriel Star, my girlfriend.
But most importantly, you love your 4 black cats, so
and I
that
can
qualifies.
Tell them all apart. I can tell them all apart. So yeah, bringing it back to Zoom. Yeah, I mean, I think. I mean,
so there's another thing.
Things.
You get to see a person's home.
Yeah, and you get to see the cat.
You get to see their animals, and you get to see their kids and their spouses and their mothers and fathers and all sorts of things. You get to see stuff. I actually can't stand it when people use a background.
Right.
So as far as a big meeting, personally, I find Zoom better than in an in-person meeting for 2 reasons. One is that I have this meeting that I go to where there's about 15 people and it's a long table. Okay, we all sit there and we eat lunch at a long table, 15 people.
Right.
So if I can't,
hear.
First of all, I have to worry about where I'm going to sit, and second of all, I can't hear.
Right.
I can't hear everybody. On Zoom, there's democratization of the seats, right? You don't have to ever worry about where you're going to sit. And secondly, you can hear everyone perfectly. And because of the little raising hand thing, people speak one at a time and they say their piece and then it goes on. So that, there are ways in which Zoom is really fabulous. And in fact, I hope that for that meeting, I don't think this is going to be the case, but I hope that eventually that meeting will stay online rather than in person, because it's better that way. On the other hand, in the type of meeting where you're trying to socialize with people,
right? It's one at a time. It doesn't work that way.
it doesn't work that well.
Yeah, I know we've had like Zoom parties, and they don't really work. It's
They
like
don't work.
this person talks, but for classes and courses
Right.
that are interactive, where one person is mainly presenting and everybody else is watching, or even interview style where two people are interacting and the rest of the group is watching. That works quite well.
I mean, it reminds me very much of something that was that I read in a book called Misconnections. Misconnections is about a woman who loses her hearing. She becomes very hard of hearing. So she has hearing aids, but with hearing aids, it's pretty hard to catch things. And one of the things that she can't do is she can't really catch talk that's going on. She can't overhear talk. And in a Zoom meeting, you cannot have more than one person, so you can't sort of have a side conversation with another person. So that doesn't work spectacularly well. But let's say you had a meeting or group where there's even 4 people and everyone's talking one at a time, and it flows pretty well. There's still something different about being in Zoom and being in person. And the question is, what is that something?
Well, I mean, even like the energetics, somebody, like, a lot of it can be sent through the digital waves and through the vocal and and video. But like even just like the pheromones in the air, like the
The smell is different,
smell, yeah, the smell, the feel of somebody, and the
but
actual
you're not
electromagnetic forces around each other, like they're not
you're
there.
not actually touching, in those situations. You may not actually ever touch somebody in a meeting of 4. You may all sit in
Right.
separate chairs and not touch each other. And so you're not really losing touch, but it feels as though you've lost touch. And that's the very interesting thing to me. Why is that? And one of the things that I think you lose is I think you lose depth. So you can come in and out. I can come closer to you, or I can sit next to you, but I can't sit next to you on a Zoom.
Right.
Right?
Yeah. Yeah. And I you did comment about virtual backgrounds, and I think this is just so appropriate for you, so I got to put it up. That's my brain.
Yeah, I know. I
Yeah.
remember when you sent it to me.
Yeah, so
It's awesome.
that's my favorite background for this.
Yeah.
Uh, but and yeah, so but we don't need that the whole time with you.
Right.
So yeah, but as far as classrooms go, with have you been doing online classrooms via Zoom?
I haven't, because I didn't teach this quarter.
Right.
I will teach again, in the fall. I don't know whether that will be online or in person. We haven't been told yet.
So I just want to bring up that I met Dr. Peggy Mason through Coursera, which is a free online courses from excellent universities like Duke and Cal Polytech and the University of Chicago and Johns Hopkins. And I began taking courses to learn how I could fix this thing, and Neurobiology of Everyday Life with Dr. Peggy Mason. And
So I think, it's interesting because obviously I was able to make that course entertaining to people and
definitely.
useful to people.
Mhm.
But it's a really different beast because you're in your own room and you're pre-recording these lectures, and the only interactions came from the forums. At the time, Coursera had forums, which were great, and then from Twitter, and from people would find me on email, and so on. But the course itself was not laid in stone. It was laid in silicon, or it was laid in digital video. So it was not changeable. So what my colleagues now are doing, what teachers at all levels are doing now, are some mixture of making videos that their students see, but also having conversations with them via Zoom. And I've seen some pretty innovative thing. That we have one math professor who managed to figure out how to get, he got an acrylic board, and he wrote, and he managed to get it so that it's a clear writing, and then his equations all show up in this bright phosphorescent blue. And the students love it. I mean, first of all, he put a lot of effort into it, and it shows that he cares. And but I think that because so many people are doing this online teaching in place of a small in-person class, they're coming up with all sorts of innovations that I never dreamed of, because what I was doing was very, very different. So I still have a learning curve ahead of me for the fall.
You had to tell me about that acrylic thing. That's pretty cool. I assume that's
Oh, it's
like
super. I'll
green
try and send
screen
you
something.
I'll send you a picture of it. It's super cool.
Very cool. Yeah, I want to know how that's done. I want to do it. That's really cool. Nice. Yeah. Well, it's interesting how how the age of COVID has changed a lot of things of how we interact with each other, how we teach. I mean, so many schools have been shut down. Basically,
Most school, I don't think there are many schools that are open.
no.
I know that Norway just opened schools for kindergartners, because for I think they did it in such a smart way. First of all, they reasoned that kindergartners really don't know what the heck is going on.
Mm-hmm.
Um, and it's a pretty critical time in their lives. So they brought them back with very few students in one classroom, and then they just used all the classrooms and all the teachers, so that they're able to hire more teachers and spread out the kids. And the kids come in and they wash their hands, and every hour they get up and they wash their hands, and they're able to actually get part of what is normal for a childhood. A little distancy normal, but a little normal anyway. A step towards normality, shall we say?
Yeah, I like that. I think that's
Yeah.
cool. The biggest argument I've heard against that is that while kids are far less likely to to have trouble with the disease, with the virus, or to be hospitalized or have symptoms even from the disease, they still can spread the virus. And what do you think
Well,
about
I don't think that they're trying not to compromise the public health um precautions that are in place. They're basically taking these kids in a safe way. So they're not sitting next to each other. They're all sitting 6 feet apart. They have one teacher, and they're getting a few hours of sort of normal school exposure. I think it makes sense. I worry a lot. I mean, it's hard to imagine what this episode of COVID what difference it's going to make in a person's life when it hits them at such an important period of the time. I'm 60. It doesn't sort of matter that COVID. I've become a person. I don't have to go through a critical point in development. I'm not a kindergartner. I'm not even an adolescent or a young 20s. I'm not graduating from high school or graduating from college. So for it to hit me now, okay, I can weather it. But for these people, for these individuals, where COVID is coming at a real milestone, a landmark in the life cycle, it's, what are the consequences of that? It's so anything that we can do to lessen those severe consequences for kindergartners and adolescents and graduating seniors from college and high school, I think we have to try to do. I think you're on mute.
Happens every time. So that's often a thing that happens. That's a very important thing that you brought up, is the consequences of the social climate that we're in, and what I see a lot of, um, unfortunately these days, there's a lot of fear surrounding things, and fear is very contagious, and especially to young young kids. And so, as far as like don't touch people, don't, stay away from grandma, you could kill her, and things like that, like what that could do to children's
Yeah,
upbringing, to their psyche, and
yeah,
their behaviors in the future.
yeah. I know.
Yeah, it's
I have a niece, and we go and we see her from many feet away, and there's no hugging, and that's
right.
so weird.
Yeah, yeah, yeah. It really is, really is. I think, I interviewed Dr. Alex Vasquez early on, and he was essentially like, if your defenses are strong, that that what did he say? He said anybody could get killed by a chihuahua if their defenses are weak. But if you're strong and your immune system is built up and your defenses are strong, that chihuahua becomes irrelevant. And I thought that was really, really powerful for like.
Yeah, I don't think that's working for people right now. I mean, there are a lot of people that are incredibly healthy, young, have no precondition pre pre-existing conditions, and are getting extremely sick and also dying of COVID. COVID doesn't really care. Doesn't really care about that.
Yes.
There, to assign personal responsibility of strength to overcome COVID, I think is a dangerous it's a dangerous trope. You don't have the strength. You could get this thing, and it's going to do whatever the hell it wants to do to you. And you could come through unscathed, or you could die. But COVID has a frightfully a frightful armamentarium of ways that it can mess with you. And it's a complicated disease that people don't understand. We don't have good treatments yet. I mean, every day there's better treatments. People are going on ventilators far, far less often, right? Because now there's other ways to get to accomplish what early on was being accomplished with ventilators. So that's great. But to tell people that, you just need strength of mind to get past COVID, I don't agree with that.
Not of mind, definitely not of mind. But
Not even of body, because the way it's attacking you is not part of your, it's not susceptible to your to how healthy you are.
I was curious if you've seen the research on intravenous vitamin C and COVID. Have you seen any of that research? Check that out. Check that out. Take a look around. It's not FDA approved, which is actually kind of ridiculous considering the safety and efficacy of it. But yeah, check that out. I think
I'm
it's.
in general a skeptic.
I know.
I'm in general a skeptic of I mean,
I
if there
know.
really was a solution, it would go like wildfire.
Yeah,
I don't. Do you
I'd
remember
love.
Do you remember the Day of the Triffids?
What's that?
Do you remember the Day of the Triffids?
No.
Day of the Triffids is a great science fiction. It's based on a book called Day of the Triffids by John Wyndham, which is one of the great all-time science fiction books. And the Triffids, which are these carnivorous plants, take over the world until somebody figures out that they melt in seawater. Okay, and so then, okay, problem solved. They melt in freaking seawater, and that spreads like that solution spreads like wildfire. If there was something that was really working, people would use it. Like, for example, people have figured out how to not put people on ventilators. So a small proportion of who was going on ventilators initially is going on ventilators now. That spreads. So if vitamin C is going to be all that, it'll spread. That's my attitude.
Yeah. I wish I agreed with you, but my experience has been like that hasn't been happening with safe and effective treatments. A lot of the times that aren't profitable don't get picked up. Um, this has been my observation of things. I think it's worth checking out and seeing what's out there. I interviewed Laura Bedell, and she works in emergency rooms as a registered nurse, and she absolutely believes in the power of vitamin C. That doesn't change anything with the climate of our medical system currently. However, it's absolutely it's out there and it's interesting. It's being used in China and things, but not in our country. And just an interesting aspect that in our audience, like, check that out. Go to not PubMed, because that's a government site, but if you go to Google scholar.google.com, and type in intravenous vitamin C and COVID-19, just take a look at some of the studies, and that's it. Then judge for yourself on that one. But I think it's very interesting. And yeah, what else would you like to talk about, Peggy?
I think that's good. We have taken up an
I think
hour of
we're
our
right about
audience's
at that
time.
hour mark. So thank you, my friends, for being here for this interview, and thank you so much, Peggy. It's always so awesome.
Always wonderful to see you, Kevin.
So good. It's
You're
so
looking great, by the way.
Thank you. You too. You too. It's the Northwest. We're both out in the
I mean,
North.
there are silver linings to COVID.
It's
Where
true.
I think a lot of us are sleeping better and eating better and spending time with family and less stressed.
Which is
So
very important for our immune system, anyways.
yeah,
So yeah. Well,
or
thank you so much.
those of us who are lucky enough to have jobs and some kind of income. Yes,
Yes, and
my heart goes out to my sympathy goes out to those who do not.
likewise. Yeah, absolutely. Well, thank you all so much for being here. Again, this is the empowerment series. Stay empowered. Healthiest thing you can do for your brain, body, and soul is to empower yourself
Believe in yourself.
and believe in yourself. Absolutely. Thanks so much. Oh, Peggy, where can people learn more about you?
My blog, thebrainissocool.com.
Yeah, and it is so cool.
Yeah.
And how many O's are in so cool?
I think if you just go, the brain is so with one O, cool. I think it gets you there.
All right, cool.
But I think then I have a lot of O's. Yeah.
You do. Awesome. Well, thank you all so much, and we will see you next time.
Okay. Bye, everybody.